Good afternoon, everyone, and welcome to another episode of BAEP Talks, a discussion with a person of interest who has experience living with, managing, treating, and/or supporting others with a chronic mental health disorder. I am Dr. Rashida Daisley, and I'm your host, and I'm also the Vice President of the Barbados Association of Endometriosis and PCOS. Today, I'm very, very excited to have Dr. Janelle Jackman with me today, who will be discussing fertility and fibroids with us. So let me just tell you a little bit about Dr. Jackman. So Dr. Jackman was born in the culturally diverse Caribbean island of Trinidad and Tobago and is an accomplished physician in obstetrics and gynecology with a passion for reproductive endocrinology as well as fertility. She has an intrinsic desire to help families while stretching the boundaries of modern medicine. Dr. Jackman obtained her Bachelor of Medical Sciences degree, as well as her medical degree from the University of the West Indies St. Augustine campus. She specialized as an OBGYN at the Brooklyn Hospital Center, graduating at the top of her class with research on reproductive health. She is an excellent skilled surgeon with extensive experience performing both laparoscopic as well as robotic surgery. Dr. Jackman is an active researcher and honoree of many awards. She has published manuscripts in high-quality medical journals. She is passionate about education and loves sharing knowledge. As such, she teaches resident physicians and medical students alike, as well as writes board preparation questions in OBGYN. Dr. Jackman strives daily to provide comfortable and caring environment in order to ensure her patients are fully able to get their reproductive needs and goals addressed. Good afternoon, Dr. Jackman.
Hi, afternoon. How are you?
I'm doing well. How are you today?
I'm great.
So, as I mentioned, today we'll be discussing uterine fibroids and how that deals with fertility. So before we dive right into it, would you be able to provide our listeners with an overview of what fertility is and what you do in your clinical practice?
Okay. So basically, infertility, I should say, is the inability to be able to conceive or get pregnant after a year of trying. And this is the basic definition. So it's actually a disease preventing a couple from being able to conceive after trying for a year. So when you say trying, we mean that you're actively trying to get pregnant, meaning that you're having regular intercourse at least 3 to 4 times a week without any form of contraception. So no condoms, no pills, no intrauterine device, nothing to stop a pregnancy. And the reason why I said it's a basic definition, because we do have caveats depending on your age, what time frame we will adjust before we intervene. So 1 year time frame is typically for patients under 35 years old, 35 and under, who have no other other obvious reproductive problems or previous surgeries or anything like that. From the age group between 35 and 40, we tend to say at 6 months of trying, then you can come for intervention. And if you're over 40 and you're ready to have a child, to be honest, you can come and, seek fertility care and counsel without even having to try, just because as women age, we know that our fertility declines.
Yes.
So the treatment plan also kind of reflects the increasing age of a woman, that decline that usually follows.
Okay, well, thank you very much. Go ahead, sorry, you're about to say something else?
Your second question was what do I do in my clinic? So basically, so I'm at OBGYN, as Dr. Daisley identified before, but I do have a big passion for infertility. And, this is where what I really enjoy doing, helping people achieve their pregnancy goals. And I currently work in a fertility center, and hence, I see patients day in, day out coming with various reasons, presenting with different factors for infertility, and then trying to navigate that to help them achieve their pregnancy or pregnancies, depending on how many they want.
Okay, so that sounds like a lovely job, and I'm sure that you're doing very well, and you're really helping your patients achieve their goals. So speaking of you're welcome. So speaking of infertility, that kind of ties into our topic today. So our topic today is actually uterine fibroids. And obviously as a physician myself, I do know that quite a number of ladies, particularly women of color, do suffer with fibroids. So let's begin the conversation by first of all defining what fibroids are.
So a fibroid is described as a non-cancerous growth in the uterus. It's usually the same, similar to the muscle layer of the uterus. So the uterus is made up of an inner layer, which is what we typically shed, and that grows and expands. That's the endometrial, the inner endometrium layer. Then you have the myometrium. Myo is like muscle, so that's the muscular layer. And then you have that outer layer, the serosa. So that myometrial layer, that muscle layer, is typically similar to the consistency of what a fibroid is going to be made up of. That's smooth muscle. And the fibroid is non-cancerous, so it doesn't mean like if you hear you have fibroids, it's like, oh my gosh, I have cancer. It is considered a tumor, but tumors are cancerous or non-cancerous. It's a non-cancerous tumor. And it can grow on that outer surface layer, on the external aspect of the uterus. It can grow within the muscle, or it can grow inside of the cavity, the endometrial layer of the uterus. And depending on how much you have, where it grows, and how big it is, determines the different effects it will have on the patient.
Okay, so are there different types of fibroids?
There are different types of fibroids, and it's classified. There's several different classifications, but I'm just going to go along the lines of what I was explaining before.
Sure.
So I would classify it based on two different things right now. So we have a FIGO classification, subclassification of fibroids. I'm not going to go to the distinct numbering because I think it's too extensive for this discussion.
Yes, agree.
Basically, based on if it's on the external surface, it's called a subserosal fibroid. And then there are different stages that the fibroid can be located within the muscle. So it could be intramural fibroid, that's within the muscle. And then it could be a submucosal fibroid, that's the one inside of the cavity. When it's inside of the cavity, because we're talking about infertility, so when it's inside of the cavity are the ones that have the biggest impact on fertility. Subserosal, the ones on the external cavity, have the least impact, and the ones inside the cavity has the most impact because that's where your baby wants to grow as well. So if you have something blocking it, that's why it will have such an impact.
Yes, so that makes sense. So what about the prevalence of uterine fibroids? So do you have any idea in terms of what the percentages are both internationally as well as within the United States where you practice?
Well, the numbers vary quite a bit depending on what sort of research you read. And the variety of numbers tend to happen because some research tend to do, they look at self-reported fibroids, so they look at prevalence based on self-report. Others look more objectively in the fact that they will take a cohort of patients and look at ultrasound diagnosed fibroids.
Okay.
So some studies will give you the range of fibroids being anywhere from like 3 to 16%. Other studies will tell you that fibroids, particularly in African American or Black patients, could go as high as 80% when they're in their 50s. So it depends on what you read, but overall, I think the general consensus is that fibroids are very prevalent, particularly in the Black community more than any other ethnic background. And as you get older, the prevalence increases. So it's a very common phenomenon to have.
Okay, agreed. So you raised a few points there that I do want to elaborate a bit on. So obviously the first one being women of color. So we do know that fibroids are more common in women of color. Is there anything other associated with our particular population, for example, the time they occur or the rates of growth that we need to be concerned about?
So as I touched on a little bit before, as you get older, fibroids get more prevalent. Women of color have been, we tend to be diagnosed with fibroids much earlier, at a much earlier age. The severity of symptoms tend to be more severe compared to other ethnic backgrounds that have fibroids. And the rate of growth is also much more rapid. So we tend to have fibroids that can get much bigger. So you can see patients throughout their lifespan, with fibroids that increase gradually in size. And well, Dr. Daisy and I went to the same medical school, so that's actually we know each other from before. And I'm sure you can recall, like, you know, obstetrics and gynecology rotation even in the Caribbean, and you still practice in the Caribbean, having patients with fibroids where they literally look pregnant.
Yeah.
That's how big the fibroids can get. And
Yeah.
we actually classify the fibroids when they're so big. We actually try to estimate the size based on weeks of pregnancy. So we will be like, you know, this is like a 20-week size uterus or 30-week size uterus, comparing the size of that fibroid uterus to pregnancy. So patients of color tend to have earlier diagnosis, rapid growth, and more severe symptoms because of the fibroids compared to other patients. Yes.
Okay, okay. So let's get right into what we're really talking about here today. So how do the fibroids themselves really affect fertility?
So fibroids, first of all, that question is debatable, and you will find two schools on it. Some people would say actually that fibroids don't directly affect fertility, and I think to an extent I am sort of with that schooling.
Okay.
And other people would say, you know, fibroids have a direct effect on fertility. Fibroids in itself, I think, don't necessarily affect your fertility, as opposed to affect more your implantation and the ability to maintain a pregnancy. So patients with fibroid tend to suffer more from what we call recurrent pregnancy loss, as opposed to their prevalent fertility issue being not being able to conceive altogether.
Mm-hmm.
So fertility, as I said, is the inability to get pregnant after 1 year. But that was the basic definition. If we go a little further into the definition, even if you're able to get pregnant, but you keep losing your pregnancy, you're still going to be classified under, you know, this umbrella term of infertility, because ultimately your goal is not really pregnancy either. Your goal is to have a child,
Yes.
and to have a child, a live birth, you know, a child that, you know, actually is born alive. So even if you are able to get pregnant, but you keep losing the pregnancy one way or the other, keep having miscarriages, you still fall under infertility. And this is where a lot of patients who have fibroids, especially large fibroids within the uterine cavity, will fall. Some patients will actually have problems getting pregnant in the first place. And this happens for multiple reasons. It's because fibroids could be found literally anywhere in the uterus. It's not located to one location in terms of the external surface, the muscle layer, or the internal surface. But apart from that, it can be in multiples, particularly in people of color. We have fibroid. We don't, you know, typically have one fibroid. If you have fibroids, you tend to have multiple fibroids, and they tend to be on different layers. So you may have some on the external surface, some on the inner layer, some on the internal surface. And this is how it really impacts your fertility. So depending on the size of the fibroid, the location of the fibroid, and how many fibroids you have, your fertility is going to be impacted in different ways. So for example, a fibroid that may be very close to your fallopian tubes may impinge and close the fallopian tube, and that can affect fertility, because the fallopian tube is your transit for your egg and subsequent embryo. That's how it gets inside the uterus. So if for any reason a fibroid is blocking off, or even kinking, or affecting the tube, that's one aspect that you can affect fertility. If the fibroid is in that submucosal layer, which is what is really inside the uterus or projecting within the uterus, sometimes patients are able to get pregnant, but when the pregnancy tries to implant or get further rooted, I like to call it, like a seed. So, you know, it has like a very thin layer of, let's say, topsoil over this fibroid, but this fibroid is like a rock.
Yeah.
So as that pregnancy tries to continue to grow, that rock is going to prevent the roots, which is the placenta and all the membranes and stuff that tries to like infiltrate inside the uterus. That fibroid is going to prevent that from happening, and hence the pregnancy is going to have limited blood supply, and it would not be able to sustain the pregnancy. And hence people tend to experience that as the inability for the pregnancy to implant or like root, or they may have a recurrent pregnancy loss. So there are different ways that the fibroid could typically affect your fertility, but what tends to be more common is implantation or having that pregnancy loss, because that fibroid, particularly ones inside the uterus, is affecting the placentation of the pregnancy.
So you talked just now about the location of the fibroids, but as you said, we do normally have multiple. So how do the number of fibroids affect this implantation or even fertility or the ability to carry the pregnancy very far?
I would say kind of like real estate, it's more within the location as opposed to within the number. But if you do have a lot of fibroids, particularly within the cavity, especially if they're large, then it probably would affect more than if you just had one fibroid on the external layer. So the amount of fibroids you do have could have a great impact. But I mean, we have had many patients who have multiple fibroids and still get pregnant time and time again because the location of fibroids are not at a critical location that will affect your pregnancy. So the number, as I mentioned, could have an impact, but it's really still linked to where the most of your fibroids are located. Yes.
Okay.
When I gave the classification before, there's another classification that I didn't mention. There are some fibroids that tend to grow on stalks. We call them pedunculated fibroids. So they look like a little bean sprout with that little stalk and the fibroid on top. And those fibroids tend to be like, it's probably one of the more ideal ones to have, especially if the stalk is thin and that fibroid is located on the external layer. It's easy to remove. It has the least impact on your pregnancy, as opposed to if you have like a fibroid where it's the fibroid itself, that broad-based fibroid without a stalk growing from your uterus.
Okay. So if I'm a lady and I have fibroids and I've been having recurrent pregnancy loss, what are my options in terms of managing the fibroids pre-conception?
So pre-conception, I would say, the question would be better geared to what preconception fertility workup you should have. Okay. Because many people tend to think, I have X, not getting pregnant, so it's X, and that's not true. Fertility is like a far complex process that can definitely be related to X, or it doesn't even have to be related. So having a fibroid and not being able to get pregnant is not equivalent, and it's not the same thing as saying you have a fibroid, so the fibroid is preventing pregnancy. Okay. So the first thing, if you realize that you experience infertility, you should see your gynecologist, and subsequently you may need further treatment from a reproductive endocrinologist. And what you're going to do with these initial initial visits, is that we're going to truly assess to see what are the different factors that might be preventing fertility. The fibroid may definitely be one, but I mean, there's so many things. There's your brain has to play a part in your fertility, any previous chronic medical conditions, your uterus itself beyond fibroids, your fallopian tube, whether it's open or not, your ovaries, whether they're producing follicles, which has eggs, and if they're releasing those follicles, and then your partner who has sperm, and the sperm has several factors that could go wrong with it as well. So anyone experiencing infertility, regardless of if they know they have a possible cause or not, should experience a full workup to try and narrow down the various possible reasons for your infertility, whereas the fibroid may be the sole factor, or there may be other things to address. Now, if let's just say you do your full workup and fibroids is the only problem that we can find, then in preconception mode, then it will depend on how much we're thinking this fibroid is contributing to your infertility. So for example, a large fibroid within the uterine cavity, we will definitely consider removing it, especially if you've been trying to get pregnant for a substantial amount of time. And I'll give the typical example of 1 year as the time frame. So ways that you can remove fibroids depend also on their location, and depends also on whether they're on a stalk or if they have a broad base. So the 3 typical locations I gave before: inside the cavity, the muscle layer, or the external surface, will depend on what will be easier and how easier it will be to remove. When we're going to talk fibroid treatment, there are different modalities, and we take into consideration, as I said, the amount of fibroids, the location, whether it's on a stalk or not, but most importantly, your fertility goals. Somebody who is not trying to get pregnant will have more options or different options to somebody who's trying to get pregnant. So I'm going to run with the first example of people trying to get pregnant, because we're talking about fertility, obviously. So if you're trying to get pregnant and you have fibroids, and you're trying to get pregnant at this moment, I should say, then, you know, it may be in your best interest to remove the fibroids if we think that it's having an impact. For fibroids within the cavity, we do something called a hysteroscopy. and we can remove the fibroids via hysteroscopy. Hyster is like your root word for womb, and scopy is basically any sort of scope, which is like camera. So we're going to take a camera and look inside your womb because the fibroid is in the cavity. And then we can take specialized instruments that can remove it. And this instrument can be a manual scissors. It can be a resectoscope that uses a little bit of a current, or it can be something called like a MyoSure that has a little chomping background. So it's like it eats away at the fibroid, so to speak.
Okay.
And these can be done within the uterus. So you're putting a tiny device with a camera through the vagina, inside of the cervix, which is the mouth of the uterus, inside of the uterus. They're directly visualizing the fibroid and removing the fibroid that way. If your fibroid is on the external surface and we deem it, maybe it's really large and we think that it may still have an impact on fertility, then we can't go through that same route because, externally, we're not going to see anything external inside the uterus. So therefore, we can opt for a laparoscopic removal. So once again, scopy, the scope with a camera, and laparoscopy is making tiny incision on the abdominal wall using a camera, and similarly removing that fibroid through that little hole with a camera. These are minimally invasive procedures, which means that we're not trying to like literally do open surgery, and this reduces your pain post-procedure, you heal much faster, you have less blood loss. If you have multiple fibroids and we have to actually enter that muscular layer, depending on the skill of the surgeon, they can still do this laparoscopically, but most people may then decide to do that an open myomectomy. So myomectomy is the fancy term for all of these, all that I described before, all myomectomies. And that's the fancy term basically meaning to remove a fibroid, but there are different ways you can do myomectomies. Via hysteroscope, because I'm having a tongue twister. So you can use a hysteroscope. Yeah. And we can do that via you removing the fibroids inside. We can do a laparoscope, you doing it to the external surface or in the muscle, or we can do open myomectomy, which is where, we make an incision in the abdomen and we remove each fibroid. And I always recommend people, including, for myself, I tell people you always have to do extensive research on your surgeon and ensure that they're skilled in the modality choice that they're going to do.
Okay, so you touched there about myomectomy, which we know is just removal of the fibroids. So how soon after maybe I had one of these procedures would I be able to get pregnant? I know it might vary depending on what procedure you had. So maybe you can just touch on that a bit for us.
Okay. So it really depends depending on the procedure you have and how many we've had to remove and the locations. But typically, I say that most people would advise 3 to 6 months. I tend to go more to 6 months than 3.
Okay.
So a quick example, somebody who has a fibroid on a stalk and it was on the external layer of the uterus will not need to wait as much time as somebody who we had to really cut into the uterus, especially if we had to actually go into the endometrial cavity while removing it. We try not to. Sometimes you still end up doing that. And for anybody who the endometrial cavity has been entered from the external surface during surgery, we tend to put you on a longer time frame for recovery. So I would say 6 months is usually a standard time frame. But some people would do 3 to 6 months.
Okay, so let's say I wasn't able to have the myomectomy, or maybe I got pregnant and I wasn't even aware that I have fibroids, which sometimes is more commonly the case. So what are the risks to my pregnancy and going forward if I have fibroids?
So a lot of people who have fibroids would be asymptomatic, as you said, and this asymptomatic state will continue during pregnancy and they will be fine. Many patients during pregnancy actually experience, the ones who are symptomatic will experience pain. Pain with fibroids are very common during pregnancy, and what tends to happen is getting all its blood supply from your uterus all this time and nothing prevents it. Now you decided you have this pregnancy, you have this baby, and guess what? The baby's preferentially getting that fibroid's blood supply, and that baby and the placenta is taking all the blood. So the blood tends to be diverted from everything else to try and, give blood to this baby, right? And what happens is that the fibroids tend to, with the decrease in blood, it tends to do something we call degenerate, meaning because of the lack of blood, it, sort of, it loses the blood supply, so it starts to kind of starve off, die off,
Yeah.
and this causes extensive pain. There are different types of degeneration, but the degeneration of the fibroid causing pain happens during pregnancy typically. So a lot of patients that you experience during pregnancy will have either no symptoms at all. If they do have symptoms, it tends to be pain.
Okay.
People who have extremely large fibroids, depending on where it is located, you can have malpresentation of the baby, meaning that the baby, when a baby is getting closer to term, closer to delivery, it tends to go head down because the head comes out first to the vagina. If you have a really large fibroid, particularly lower down, closer to the cervix, it may prevent the ability of the baby to present head down, and your baby might be in different positions, and it may warrant needing a cesarean section. So those are the more common things that happens with fibroids in pregnancy.
Okay, so from what you're saying, that the fibroid degenerates, so the fibroid wouldn't necessarily grow during pregnancy?
Some fibroids, but it's not necessarily the majority of them. Some people think about 10 to 20% of fibroids grow during pregnancy, but the majority tend to either remain the same or undergo degeneration as opposed to grow.
Okay, so you touched on another point there in terms of C-section or cesarean section. So if I have fibroids, or if perhaps I had a myomectomy before I conceived, would I need to have a C-section in any of these cases?
So once again, it depends on the procedure that was done. So if you had a myomectomy and the endometrial cavity, which is the cavity of the uterus, that innermost cavity was entered, then I would think most people, at least from the way I practice in the US and according to the American College of Obstetrics, would go for cesarean section. If you had fibroid surgery and the cavity was not entered, or it was a small fibroid on a stalk that was just, the stalk had to just be cut, then it's not necessary to have a cesarean section. People would try what we call trial of labor after a myomectomy. These patients will be monitored closely, especially for pain and different symptoms, and their tracing of the baby's heartbeat will be monitored closely. Anyone who has had a myomectomy, even if it was a more simple procedure, is at risk of having uterine rupture. The risk increases depending on how more invasive your surgery was. So if you had a lot of fibroids, particularly fibroids that was found on the upper half of the uterus, like the fundal aspect, because this is the part that really contracts when you're in labor. If you had to enter the muscle layer, and worse yet, if you had to enter that inner layer when removing the fibroids, so you enter the innermost cavity, and if you had really large, extensive fibroids, then these are all factors that will tend to push you more into electively choosing cesarean section as opposed to trying labor, because these factors will increase your chances of you having uterine rupture. So it's always kind of safe to err on the side of caution. Where I practiced obstetrics and gynecology for the past prior 4 years before I went into a more fertility field, our rule was more or less myomectomy was equal to cesarean section. But that's not necessarily because that's what you have to do. We just always err on the side of caution because we had more high-risk patients who presented late, who, took less care, lower socioeconomic. So they weren't as necessarily always as informed as how their surgery was done. So that left us in the dark. So we sort of more into a more cautious way of practicing. But if you, let's just say you did the myomectomy and you knew the location and stuff, then you obviously could tailor how, what modality of delivery would be best. But I would say it's not a hard and fast rule, but I think most obstetricians, particularly in the US where litigations are high, will err on the side of caution and will probably tend to be that myomectomies will almost, especially if it was high in number, high in location, and you enter that cavity, will almost be equivalent to a cesarean section. Though, as I said, there are exceptions to the rule.
Okay, so you touched on something there. For those out there who might not be aware, what exactly is uterine rupture?
So uterine rupture, it's exactly what the name suggests. It's literally the uterus opening up. And it typically happens in the third trimester, closer to labor, well, during labor, closer to delivery. So different factors. Anyone who's pregnant could have uterine rupture. It's extremely rare if you've never had any uterine surgery or any problems with the uterus. So it's more common in patients who have had previous uterine surgery, myomectomy, as well as previous cesarean section are the two most common surgeries that people tend to have on the uterus that will make them at risk of having uterine ruptures. So we take a lot of precaution, especially the factor that I said in myomectomies, you could have surgery on the fibroids on the top of the uterus, which is the contractile part. And obviously, you know, just like anything breaks at its weakest link, a uterus will rupture at its weakest aspect, which sometimes could be the scar of previous surgery.
Okay, so you mentioned in terms of the fibroids being at the very top of the uterus, but what about them being in the lower aspect, the lower segment? How does that affect pregnancy and perhaps delivery?
So if you have fibroids in the lower segment, it could affect fertility depending on its proximity to the cervix and what's its relation in the cervix. If you're pregnant and you still have that fibroid and it hasn't been removed, depending on its size, it could cause, as I mentioned before, malpresentation, meaning that your baby will not be the characteristic head down that we want for delivery. It can also cause obstruction to delivery if your cervix, the mouth of the uterus where the baby is supposed to come out of during birth, if that doesn't open because of the fibroid. So a lot of patients who have fibroids in that lower aspect may have to undergo cesarean section if you have any sort of malpresentation of the baby, or if you're not getting that full dilation or your fibroid is being obstructive to the delivery. If the fibroid was there and you had surgery in that lower uterine segment, then the risk of rupture is not as high because that lower aspect tends to be thinner and it's less muscular than if you had surgery in the upper aspect. So your high risk are patients who have surgery in that upper aspect of the uterus called the fundus and the main body of the uterus, because all that contractile tissue is there. So the sheer force of that power of contraction of the uterus can actually, if that scar is very weak, cause that scar to rupture open. So the lower the fibroid is usually malpresentation, indication for cesarean if the baby is not presented right or if there's obstruction to delivery.
Okay, so also in terms of the baby, you spoke about the presentation, but what about the baby's growth, particularly if the fibroids are actually quite large or numerous? Is there a possibility that the baby might not grow as well?
There is a possibility that the fibroids are extremely big, that the baby may be a little small for its size, but typically fibroids, I would say the majority of fibroids don't impact the fetus as much during pregnancy as, you know, people would think that it would. So typically fibroids in pregnancy, you're already pregnant and you have fibroids. The main impacts tend to be pain as opposed to an impact directly on the baby. But there are instances, depending on the size, that the fibroid could affect fetal growth, and more so, depending on location, it could affect fetal presentation. In terms of cesarean sections, fibroids could also be a little pesky during your cesarean section, especially if they are located within the line that we want to make that incision, because fibroids, as you mentioned before, tend to bleed a lot. So we try not to disrupt a fibroid during pregnancy if we don't have to. And definitely we try not to have to touch it during cesarean section. Most people think, oh, well, I have a fibroid, you're going to do a C-section, take it out one time. But the gravid uterus, the pregnant uterus, is receiving so much liters of blood. Almost your full volume of blood goes through your uterus during pregnancy, and it's absolutely the worst time to try and remove a fibroid if you don't have to. So if a fibroid is located at the line of incision, we may be forced to remove it. Otherwise, a fibroid during a cesarean section, we tend to leave alone, because any incision to your uterus, including the cesarean incision, that's cystotomy, any incision can lead to bleeding, and you're bleeding volumes of blood because your uterus is so has such a high volume blood flow that we try to avoid interfering, removing, doing anything related to fibroids. Even if it's in the front, we have access. If we don't have to do it, we leave it alone. So fibroids could increase your bleeding post-pregnancy. So we try not to have to manipulate it in a cesarean section, or if you did a vaginal delivery, we may have to give you more medication to help with the contraction if your fibroid is being posing a problem with your uterus trying to contract back to its natural size.
Okay, so in that postpartum phase, after lady has delivered successfully, she had no issues. In those initial maybe 6 weeks or so, is there any advice that we should be giving a postpartum lady with fibroids in terms of what to look out for? Anything that we should be concerned about in that phase?
We want all women to look out for bleeding, to be concerned if they're changing pads very frequently. 1 to 2 pads every hour is too frequent to be changing pads. And post-pregnancy, you have something called lochia, which is that bleeding that occurs after pregnancy. And that should be gradually declining as your days and weeks go by. If this is remaining the same or if it's getting more frequently, these are things that are concerning. And, you want to revisit your obstetrician and gynecologist and be evaluated to make sure that you're not having like secondary postpartum hemorrhage. Other than that, patients would look out for the pain, the bleeding, and that tends to be across the board. I don't think there's anything unique for patients with fibroids to be too concerned of in the postpartum phase. What I can say though is that, if they were planning to remove the fibroids, then we're going to wait minimally 6 weeks. We tend to wait a little longer, but minimally 6 weeks before we do anything in terms of removal, because we try to get in about 6 weeks, 6 to 8 weeks, we're getting more to that pre-pregnancy state. And hence the uterus is going to be more contracted. So the blood flow to the uterus is going to be less, and it's a safer period of time to do anything concerning surgery as opposed to if you did it prior or during that immediate post-pregnancy phase.
Okay. So I think it would be a little remiss of me if I don't ask questions about fibroids outside of pregnancy, because I know a lot of ladies are listening might not be thinking about getting pregnant, but they do have fibroids. So in terms of the management of fibroids outside of pregnancy, what procedures are offered to those ladies outside of maybe myomectomy?
Options we will use will depend on what your main concerning symptoms are and what your goal is, your eventual goal. And the eventual goal relates back to pregnancy, because you may not want to be pregnant now, next 5 years or 10, but maybe you will say, in X amount of time, I want to get pregnant, and that still needs to be considered. So when I give answers, I like to generalize it into medical management, surgical management, and then we have like a little in-between category for fibroids that I'll explain. So in terms of medical management, you have like your birth control pills. So particularly if your presenting symptom is like heavy menstrual bleeding or the cyclical pain that happens with your period, then birth control pills, especially if you're not getting pregnant at this point in time, is a good option that you can have, because with the reduction of the hormones and the cycle of the hormones will also affect the fibroids, because the fibroid responds to the hormones. It tends to be considered to be responding mainly to the estrogen, but some studies also show the progesterone. So both hormones that you have cycling during your menstrual cycle. So by giving you birth control pills, we stabilize this and prevent ovulation, and hence you may have a reduction in your blood flow as well as the pain that happens with fibroids. More simplistically, I should have just started off with like NSAIDs. You can take like Motrin, ibuprofen, whatever you know it as, Motrin, ibuprofen, they're actually the same medication under the umbrella term of NSAIDs. And if pain is your presenting symptoms, this will, help greatly with your fibroid pain. Whether it's cyclical or non-cyclical, your NSAIDs will help a lot with your pain. So we have NSAIDs, we have birth control pills. And next classification of medications that also deals with the hormone, but it's a little more aggressive than the birth control pills, will be using gonadotropin, releasing hormone. I would say agonist, antagonist, because they both can be used, but we tend more to use the agonists. And these medications, they control the cycling of your hormones, but from more like a brain level, as opposed to birth control pills. Well, it's also technically on the brain level, but anyway, but these hormones are a bit more aggressive. So, it's a kind of step up medication, and it's not meant to be used long term, as well as it tends to be used best in the setting of patients who have like really large fibroids or bleed extremely heavily, but are coded for surgery. So therefore we can minimize, shrink the fibroids as well as decrease the blood flow, so that when we go to do the surgery, you know, it's smaller fibroids and it's less blood loss in the surgery. So those are, I think, the majority of your, what do you call it? The medical, yeah, the medical treatment that we have, that we tend to use for fibroid treatment. Then we have like a little intermediate category that have several little things. I could kind of classify one of these as medical therapy too. We can use what we call an intrauterine device, an IUD. You must have heard of it before. And the progesterone one, so there are two different ones. One has hormone, which is a progesterone, and one is copper. The copper will be horrible to use in cases of
do not.
Especially in terms of bleeding, because unfortunately the side effect of the copper is pain and bleeding. So it's not going to be ideal. So we're talking about the progesterone containing IUD, and it's usually levonorgestrel that it has in it. And these IUD devices could help reduce the pain as well as the blood loss with fibroids. The one drawback of an IUD is that if you have severe distortion of your uterine cavity because of the fibroids, we will not be able to place the IUD. The IUD has to be placed in a normal uterine cavity. So, you know, the fibroids that you will have in the case of putting an IUD will tend to be the ones in the muscle or the ones on the external surface. But if you have those fibroids projecting into the uterine cavity, then IUD is not your best choice. And remember, we're talking about the progesterone containing ones. There's a medication called tranexamic acid. It's not a hormone medication, but it's a medication that you can take on your very heavy period days. And this tends to decrease the pain and the bleeding of fibroids as well. The second level I touched on, where I said the GnRH antagonist or agonist. And then we can go into what I say is like, it's not really surgery, it's not medication. This is where uterine artery embolization will fit. So where I will put it, at least.
Yeah.
Uterine artery embolization is a treatment for fibroid. It's minimally invasive. And basically, we're going to go through a vessel, one of your major vessels in your leg, and we're going to release little beads that are going to basically stave off the major arteries that are feeding the fibroids. It's done by interventional radiology, and they're going to like basically release these pellets to block off your blood supply. So we're blocking the blood supply to the fibroids, and it can greatly reduce the fibroids. However, it has not been shown and studied in women who still have fertility goals. So we do not recommend this form of treatment in someone who still desires pregnancy. So even though what they have seen so far, and it's not patients who purposely had it with pregnancy goals, it's patients who had it and still got pregnant afterwards. We haven't found any direct major negative effect of having this procedure and then subsequently getting pregnant. But as it stands right now, it's still not advised in patients who know upfront that they still desire reproductive goals.
Okay.
It has a shorter recovery time. It's, as I said, minimally invasive, but sometimes people still end up getting even more pain with this procedure, because when you block off a blood supply to any body part, it increases the pain, and a lot of patients still end up as high as about 25% still end up undergoing a hysterectomy. So that's generally the intervention. There is a focused ultrasound that you can use as well. Once again, it causes necrosis of the fibroid. And once again, we don't recommend this in patients who outright from the outset know that they want to have like they have fertility goals and want to have children. Lastly, not lastly, we talked about the myomectomies already. And then lastly, the definitive treatment, definitive meaning the treatment that will fully 100% get rid of your fibroids and all the possible complications and pain, will be a hysterectomy. And obviously, this is not a modality for anybody who desires reproductive goal, at least if you intend to carry your own pregnancy. This will not be a choice. So that's the range of treatment. We go from medical to like minimally invasive to surgical intervention to full frank hysterectomy.
Okay, so that was definitely quite a bit. And as you said, I guess it would really be tailored to the patient themselves and what symptoms they're having as well as their goals.
Yes.
Anything else you would like to add in terms of pregnancy and fibroids that you don't think we would have touched on?
Um, I think I probably just want to reiterate the fact that having fibroids and not being able to get pregnant is not an obvious cause and effect. It is possible that the fibroids could be a cause, but most times, often than not, you may have other factors leading to infertility. So I think that it's very prudent and necessary for the individual when you experience infertility, fibroids or otherwise, that you get evaluated for infertility. Do a full workup by someone who knows what they're doing to really assess what is your problems and how tailor treatment to you. It's not a one size fit all. Because your sister had fibroids and that was her reason doesn't mean your fibroids are your reason. So you definitely need to find out what is the reason so that you can get a tailored treatment. And when it comes to fertility, the sooner the better, particularly for women, because we do have a biological clock, as you always hear, our time is ticking and our fertility declines as our age increases. So these are just some take-home messages. Also, fibroids increases with our age. So fibroids increase with our age, fertility declines with our age, miscarriages increase with our age. So the essential thing is that it's going to get harder to get pregnant if you have fibroids and you're getting older.
Yeah.
So definitely the sooner you realize, it's been a year, it's been more than a year, because most patients who present to me, it's never somebody presenting at a year. It's always 5, 3, 6 years that has gone by. So really, don't let too much time elapse if fertility is your goal, regardless of what the cause is. You reach that 1 year mark, seek further help.
Great. Well, thank you so much, Dr. Chapman. I do think that this session was very, very, very informative. And I think that our clients out there would really enjoy this and get a lot of information. So I do want to say thank you once again for taking time out to come and share your knowledge, your expertise in OBGYN with us as well as our audience.
Thank you for having me. I really appreciate you today.
Yes.
Have a good day.
You too. Bye.
Bye-bye.